to the PM CST shouting session today with Dr. Mizel. My name is Michael and I'll be today's host. To give a quick introduction to Dr. Mizel, he is a staff, colon and rectal surgeon, and associate professor of surgery at the University of Arkansas for Medical Sciences. Dr. Mizel currently serves as the surgery clerkship director at UAMS and is a clinician, academic surgeon, as well as an active researcher. Dr. Mizel is the founder and director of the award-winning Business of Medicine course, and he has also been awarded the White Coat of Investor Financial Educator of the Year in 2020. Before we begin, I have a couple of reminders for our audience. We encourage you to turn on your cameras if you're able to. This session will be recorded and uploaded to our YouTube channel. And at the very end, there will be a Q&A. So feel free to put your questions in the chat or unmute during the Q&A, and we'll cover them, all your questions during the Q&A at that time. But with that said, Dr. Mizel, the floor is yours.
All right, thanks everybody. I appreciate the opportunity just to speak and kind of chat with you guys for a little bit. And I really want to make sure that at the end of this hour that you all have your questions answered and that you feel like you've learned a little bit more about a day in the life of someone like me and kind of what I do, just to help you get more information and kind of understand a little more broadly what things look like in academic medicine. And maybe this is something you've heard of before. Maybe this is not anything you've ever heard of or, or sort of been a part of, but I'll try to answer any questions that you have. Definitely want this to be much more interactive rather than me just chatting to you for the next little bit. So what I thought though is that we would get started, maybe just to stimulate kind of your mental facilities kind of going and get things kicked off. I would just I made a little PowerPoint of some questions that we can talk through, and then maybe that'll stimulate your brain to get going, and we can chat about those, or we can chat about whatever. And as mentioned, I also teach about finance for doctors, and we can talk a little bit about finance and just kind of cover whatever you guys feel appropriate. So I'm going to share my screen here and pull up the old PowerPoint. All right, so the pre-med scene brought to you by my clinical practice. So I have been at UAMS, which is the University of Arkansas for Medical Sciences. We're located in Little Rock, so the capital of Arkansas. And I've been here, I started here in 2010. And so I've been now practicing, just starting my 12th year. So to get to where I am, it was 4 years of undergraduate college, then it was 4 years of medical school, then 5 years of surgery training, then 1 additional year of colorectal surgery to specialize. And that got me to 2010. And now I've been in clinical practice, done with my training now for 12 years. So these are just some cases that I have come across over the last little bit that I took pictures of, and just try to give you some informational little vignettes. So let's talk about the first case. So this was a lady, a 32-year-old female with a history of intermittent bloody diarrhea and then crampy abdominal pain, who came to the ER with extreme abdominal pain and intra-abdominal free air on the abdominal x-ray. And I'll explain to you what that means in just a minute. So when we decided to take her to the operating room, we found some areas in her bowel that did not look abnormal, that did not look normal, looked abnormal. And so your goal is trying to figure out what it is. So let me explain to you this little clinical scenario. So you got this young female with intermittent bloody diarrhea, crampy pain that is kind of weird, not typical, obviously. And then suddenly she comes to the ER with this extreme abdominal pain. So her exam is clearly changed. And then when we talk about intra-abdominal free air, so when every time we swallow a little bit of air. And so whenever we swallow that air, it just stays within the intestines, goes through the esophagus, into the stomach, into the small intestine, into the colon, and eventually you just poot it out, just like everybody else in the world, right? Well, when somebody comes in with free air, what that means is that there's air in the abdomen, but it's outside the bowel. So that means there's a hole somewhere within the intestine that's allowing that air to leak out, which air isn't that bad, right? Because we're just touching air all the time. But the air isn't the issue. It's the bacteria and all the stuff that leaks out with the air that makes people so sick. So when people talk about, in my world, intra-abdominal free air, it's not really the air, that it's what is accompanying the air as it leaks out of the intestine into the abdomen. So what is the most likely diagnosis? In this case, this is what normal small intestine looks like. If you're looking at it like through a scope, this is kind of normal, kind of pinkish, reddish looking, very smooth, not any really big deal there. But on this lady, this is what her intestine looks like. So this area here is the same area as this, but this one is much more inflamed, much more red, swollen. This is normal over here, and this is colon, and this is appendix. So there's this piece of bowel that leads right up to the colon that is very, very inflamed, and there's this very sharp mark here where that inflammation and irritation stops, and then it immediately becomes normal colon over here. So what this is, what caused this lady's problem is called Crohn's disease. So maybe you've heard of Crohn's disease before, but it's like an autoimmune disease where the body basically attacks itself. And when it attacks itself, it will eat all the way through the wall of the small intestine, which in this case, the very end of the small intestine is called the terminal ileum. And it makes these big ulcerations like this, makes these little pockets, which are all ulcers, and where the inside lining of the intestine has just kind of sloughed off and died. So this lady came in with a Crohn's disease exacerbation, and she had perforated her small bowel. And so she had all this stool and everything in her abdomen. So I had to take her back and then take out this part of her bowel and then give her a temporary ostomy, you know, where you kind of have a thing on your belly where you poop into a bag for a while. So this is just kind of one of the cases that's sort of a day in the life of a colorectal surgeon. Somebody comes in acutely sick, and we take them back and we diagnose their trouble. This is also another manifestation of Crohn. So this is a lady's bottom, different patient, but lady's bottom. Crohn's can also affect the anus a lot. So this is somebody's anus here. But see these big, large areas kind of in the vulvar area where the skin just comes off. This is an infected area over here, or pus just extrudes out. And all this is because the GI tract is attacking itself. And so this lady actually has a hole between her vagina and her anus where stool is coming through all the time. And this can just be a terrible, terrible disease. But this is something now that there's better medical management, but something that I see all the time and deal with frequently. All right, hopefully these pictures aren't going to gross you out too much. If so, just maybe hit B on your screen and blank it out or something for a minute. So now you've got another patient that's got these complaints of this umbilical hernia, what they're calling umbilical hernia, abdominal fullness, increasing GERD, what people call it reflux, you know, gastroesophageal reflux disease. She's been losing weight. She's got this vague abdominal pain. And so a general practitioner says, or like our primary care doctor says, hey, this lady's got a hernia. Can you fix it? And so this lady shows up in your clinic, and this is what her belly button looks like. Now, I don't know about you guys, but this is not what my belly button looks like. And I hope it's not what your belly button looks like, because that's not normal. But the general practitioner doesn't know any better. And so they send this patient to me. And when I see this kind of like beefy red looking thing that's basically like eroding through her belly button, that causes me some concern. So what should I do as the surgeon? Should I just push real hard and push it back in, which is called manual reduction, which sometimes you can do with hernias? I could get an X-ray. I could do an EGD, which is an upper scope, or I could go ahead and fix her hernia if I think that's in fact what this is. Well, to give you clarification what an EGD is, it's this thing. So I do these all the time as well. So this is me holding the scope, and I have this little camera that I put it through patients' mouths, go through their esophagus, in their stomach, and into their duodenum. So when I say EGD, I wanted you to see what possible information you could get by doing an EGD. The opposite of that procedure is like a colonoscopy, where we go in through people's bottoms and look at their colon that way. So these are your four options. What I would recommend on this lady actually is an EGD. Look in her stomach. And you're like, why? What's going on? Well, just whenever you study and you begin to know these things, what this actually is, if you were to scope her and look inside her stomach, this is probably what you would see, which this is gastric cancer. So this is whenever you're looking inside somebody's stomach, this big thing right here is a big erosive, what we would call a gastric adenocarcinoma. And so what has happened is the cancer has grown all the way through the wall of her stomach and is starting to spread within her abdominal wall and go to her lymph nodes. Well, we've got a few lymph nodes right around our umbilicus, our belly button. And so what this picture is this is actually a area where her gastric cancer has eroded into her lymph node, and that lymph node now has eroded all the way through her belly button skin. And so this is not a hernia, this is metastatic cancer. And we call this node, we gave it an eponym called a Sister Mary Joseph's node. Some lady discovered it some years ago, where it's this nodule eroding through the belly button that's usually either ovarian cancer or gastric cancer. There's other things as well, but the point is to say, whenever we do surgery and we get people referred to us as clinicians, we have to be smart enough to say, I don't think this is a hernia. And actually, I think there's something much greater going on here, particularly when people come in complaining of weight loss and vague belly pain and all this sort of stuff. We've got to figure out, actually, I think this lady's got something much greater going on. And so we have a lot of life and death discussions, and we have a lot of times where we have to break the news to people. Hey, this isn't a hernia. This is actually a very bad problem. All right, here's another problem I deal with. A 30-year-old male presents with rectal bleeding. And when you do a colonoscopy, you find something. So this is normal. This is what the normal inside of a colon looks like. But in this particular patient, you put a camera in there to look around and you see this stuff. So these are bazillion polyps all in this guy's colon. And so you do a biopsy on these, and these are called tubular adenomas, which means these are the type of polyps over time that develop into colon cancer. And so the question is, what do we do with it? Well, we could just repeat this procedure in 1 to 2 years. We could go through with the scope and try to remove every one of these polyps. Just go through and you kind of just pluck them off. You just plunk, 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 and just go all the way through the colon, just plunk them off. And there's probably hundreds of these things in this guy's colon. So that's not a good idea. You could remove all of his colon and then take the small intestine and connect it to his rectum so that most of his colon is gone. Or you could remove all of his rectum and his colon, so not just his colon, but his colon and his rectum, and then do this thing called a J pouch. Well, the bigger question is, what in the world is going on with this guy's colon? Well, the right answer is removing his entire colon and his rectum and using his small intestine to make a pouch, which is really weird if you've never heard of this operation. But what this guy actually has is a genetic disease called FAP, which stands for familial adenosis polyposis, which means there's an abnormal gene on his 5th chromosome that's called the APC gene, and that's mutated. And so at a very young age, usually around puberty, these people will start making tons and tons of polyps, and there's a 100% chance over the course of his life that he's going to develop colon cancer. So we have to remove all of the colon and all of the rectum to prevent this guy from getting colon cancer. So what that surgery is after all of the colon and the rectum is gone, this is a small intestine, and we use these kind of fancy tools in the operating room, and we make this little pouch, and then we connect the pouch to whatever tiny little bit of rectum and anus he has left. And this guy will have bowel movements about 6 or 8 times a day. He'll poop quite a bit, but it keeps him from having to have a permanent ostomy where he's pooping into a bag, and also prevents him from having cancer. So he can thank his family for this very unfortunate diagnosis, but nowadays it is not a death wish. You can actually fix it. This is what his colon looked like after I took it out. This is kind of what I was showing you. There's just polyps everywhere. People will say it looks like shag carpet, which I think is a really terrible description, particularly if you have shag carpet in your apartment. You may think, wow, this is, every time I look at my floor now, I'm going to think of this guy's intestine. Hopefully not, but suffice it to say, we do a lot of genetic work in colorectal surgery as well, and we do a lot of cancer work. So if you have that kind of interest, then maybe this is a good place for you. All right, I think we've got 2 more cases. Taking about 15 minutes here. We'll go, the next 2 will take about 2 minutes. So we've got this 30-year-old guy who comes to the ER with nausea, vomiting, and abdominal pain. And he has not pooped or passed gas for 24 hours, which is abnormal. He's had surgery before when he was a kid at 11 years old. And when he comes in to see you, he's got this big, distended, swollen, very, very tender belly. And the emergency room calls me as the surgeon, says, hey, this guy doesn't look so good. Can you come down here and take a look? So I look at his x-rays and I look at a couple of different things and I say, oh, this doesn't look so good. Normally, whenever you take an x-ray of somebody's belly, you should not see this much air. The air, if it's anywhere, should be in the colon. And there's a way you can figure that out. But really, we don't have that much air. We just kind of pooed it out all the time. But this guy had a lot of air, and it's air that is like stuck in his small intestine. And this is a CAT scan that shows some areas of very dilated small intestine. That's all these things that look like Cheerios, all these rings. And then he's got these areas of very, very collapsed, very small intestine. So what that means is some of his small intestine is very dilated and full of air, some of it is very small and collapse. So at some point in his small intestine, there's a transition where he goes from big dilated bowel to very small bowel. So the question is, based on this history and these x-rays, what do I do? Well, the thing to do with this guy is take him to the operating room and see what's going on. Well, what I found when I did that is because of this surgery when he was 11, he had made some scar tissue. And that scar tissue, this is his omentum, which is this like sheet of fat that everybody has in their belly. This omentum had gotten a little tiny little band, this little adhesion, that he kind of folded over and went like way down towards his back. It'd make almost like a little bridge inside his belly. And some of his bowel went under that bridge. And as after a bunch of it went through, it got so much in there, it got tight and started losing its blood flow. So I went through, and when I opened him up, I saw this, which was this bowel, which looked terrible, and this bowel, which looked normal. So I cut this little adhesion, this little piece of scar, just like, and then freed up the blockage. So because he had a blockage, that's why he was throwing up and had the belly pain. But this part of his bowel had been without blood supply long enough that I had to remove it. So I removed this section of his bowel. Y'all may have studied about Meckel's diverticulum. That's what this is. But this is another way of the way his bowels look. So this is live bowel over here, and this is all dead bowel. So I had to cut out all this intestine, and this guy actually did great. We caught it before it perforated, and he was out of the hospital in a very short amount of time. But when you have bowel obstructions or blockages, you can have all kind of problems that are associated with this. So it's our job as the surgeon try to figure out if somebody's vomiting just because they have a virus, or are they vomiting because they have a blockage, and do they have fever because it's a virus, and is their heart rate fast because they're just dehydrated, or are they about to have dead bowel? So that really becomes this really tricky thing for as the clinician to figure out, should I cut this guy's belly open or just go give him some fluids and tell him to take some Pedialyte or something and send him home? Because if you make the wrong judgment call, then he's dead. All right, last one. Old guy comes to the ER with bilious vomiting, means like vomiting like green stuff, and his belly's getting real dilated. But he's lost a bunch of weight over the last 3 months, which is kind of weird. And so he's getting more and more tired, and you do a CAT scan on him, which this is it. And what you see is, this is his colon right here, which is real big and dilated. And again, we've got air up here. This is fluid. This is way larger than the colon should be. But as the colon comes over, way over here, you see this really, really thick portion of his colon wall, which is way thicker than it should be. The colon wall is actually really pretty thin. It's just a little tiny little sliver right here, and it comes over a little sliver, and then you go over here, and it's like, boom, the radiologist kind of threw you a bone and even measured it for you and say, hey, this is 1.5 centimeters. That's weird. What's going on? Well, this is the way cancer presents. So what is happening here is this guy's got colon cancer, which is represented by this thickening. It's just a big mass in there. And so the fluid that's coming around is blocked because it can't get through this cancer. So this guy also needs surgery. And when you take him to the operating room, you'll cut this section of his bowel out. What I did, I cut that section of his bowel out and then put him back together, which basically kind of like opened up the pipes in his intestines. And he started going to the bathroom again and ultimately did just fine. But I'll show you this, and I'll show you some of these other x-rays to show you that what we do a lot in colorectal is we have to do a lot of reading x-rays. We do a lot of clinical stuff, as far as deciding when people should have surgery, when should they not. We do a lot of office-based procedures. We have to read a lot of pathology, which is looking at all this stuff underneath the microscope. So lots of different things that we do that we just get trained to do over time as you just immerse yourself in the medical field. So those are some pretty gross pictures and some situations that I run into. One more example was a guy that I did a procedure on Thursday. And then on Saturday night at midnight, I had to go in and operate on the guy because there was a complication that wasn't anybody's fault that he had as a result of the procedure. So at midnight on Saturday night, I'm working on this guy, cutting part of his bowel out and giving him a colostomy and those kind of things. So we do have those occasional kind of midnight, middle of the night deals, which are kind of a wear out. But we do have those occasionally as well. So I want to give you guys a chance just for some questions now. I can tell you a little bit more about what I do, if so desired, and then I can talk about some of the finance stuff I do. But just thought I would give you those little maybe triggers there to help you sort through some of what we do. Any thoughts or questions about that? All right, so Jennifer said, what is your favorite part of colorectal surgery? Okay, I'll tell you what is common for surgeons, and then I'll tell you what is my part. I don't know if you've ever seen the movie Remember the Titans. So it's about this high school football team, right? And there's this one part where the coach walks onto the football field, and there's nobody on the field. It's kind of like one of the end of the games, and he walks in, the lights are on, and he kind of throws his hands up. He's like, this is my sanctuary, you know? He just loves the football field. Well, there are a lot of people, I think, that feel that way about the operating room. They walk in the operating room, and there's like this sterility to it, and this order, and this very defined system that we have. And some people walk in the operating room, they're like, this is my sanctuary, this is my haven, you know, like the beeping of the pulse oximetry monitor and all these different things. Some people just love operating. I enjoy operating, but I would not say it's what I love the most about colorectal surgery. Whenever I was in junior high, whenever I was in high school, whenever I was a kid, I did a lot of things with my hands, found that I was pretty good, like fine motor wise. I always played sports, played guitar, different things. So I feel like I'm pretty good at surgery, but what I really like about surgery is the relationships with the patients. I like being able to tell them, hey, I had 3 people in clinic today that came to me with new diagnoses of cancer. And I said, I know you've seen this doctor and that doctor, but this is what I'm trained to do. I'm going to be able to take your cancer. I'm going to treat it. I'm going to cut it out. There's a great chance I'm going to be able to cure your cancer with this surgery. And then I'm going to see you every 3 months for the next 3 years. And then I'm going to follow you after that. And we're going to get to know each other well, but I'm going to be your quarterback. I'm going to take care of all your stuff. And so watching kind of the fear and concern and just like trepidation just go away and abate. And some of these people really is my favorite part, is let them know, like, I've got you, you know, I can take care of you. This is why I did all those miserable nights, you know, all night long, learning how to take care of this very problem that not very many people can. So it's interesting that surgery, because you can develop a skill set that not very many other people have, and allows you to take care of some of the sickest of the sick, really. Yeah, good. I'm glad you found that helpful. Is a lot of colorectal aspects done by general surgeons? Yes, there are a lot of general surgeons that do colorectal, and a lot of what they'll do is they'll do colorectal kind of up to a point, and then when it gets super complex, then they'll end up referring it on to colorectal. So there's this one particular type of cancer that's over in the terminal ileum, kind of cecum, basically like kind of right lower quadrant area. That's not a very hard operation. A lot of people will do that. General surgeons will do that operation. We call it a right hemicolectomy. But when the tumor gets more down towards the rectum, more down towards the anus, and gets really difficult, and particularly when it's going to involve complex laparoscopic surgery or need the help of, like I saw a guy today where he's got a tumor starting from his colon, but it's grown into his ureter that drains urine from the kidney. There's a possibility it's growing into his bladder. So I may have to remove all that, put it all back together. So in my hospital, I have urology here as well, who can help me put that stuff back together. But in small hospitals that only have general surgeons, like don't have urologists, whatever, you wouldn't want to do that surgery in that kind of place because it's too big. And so those kind of things, they don't mess with, or they shouldn't. Sometimes they do when they shouldn't. But there are, you know, like general surgeons can totally take care of hemorrhoids. They can take care of infections around the bottom, whatever, hernias, things. But once it gets real complex, then pretty much it's exclusively colorectal.
Just a quick question I want to throw out there. In terms of continuity of care, you kind of mentioned that or went over that a little. Comparing and contrasting it between colorectal surgery versus general surgery versus even medicine, what does that look like? What are the differences between those?
Yeah, that's one of the big rubs for surgery, is that people usually say that surgeons are like kind of treat them and street them, you know, that there's not a lot of continuity with surgery. And I didn't like that about general surgery. I like it more with colorectal because about 85% of my patient load is cancer. And so it's a lot of continuity. And a general surgeon in private practice in small town Texas, small town Arkansas, small town anywhere, isn't going to have as high volume of cancer that I do, but because I'm at a big academic center, a lot of the complex cancers come to me. So I do have a lot of continuity. But for some people, they don't want continuity, and that's fine. I've got a good friend who's a gynecologist that only wants to see people once a year for their annual breast exam, their pap smears, and if they get pregnant, see them a whole bunch for about 9 months and then like peace out, and that's just the way he wants to run his practice, and that's great. So I think one of the charges for you as a pre-med student and as a medical student is to figure out, what kind of doctor do I want to be? Do I want to have that continuity? Do I like that? Or do I really like to quickly treat somebody almost like a traumatic injury? Somebody comes in stabbed in the belly, you fix them, and then you're like, all right, go about your merry way, go live your life, and stay away from old boy down the street or whatever, So there's a lot of good friends of mine who are trauma surgeons that really like not having continuity. They just like those short bursts. I like the continuity. Internal medicine is probably going to be more like continuity. They don't do any surgery, but they manage a lot of chronic health diseases, COPD, heart failure, hypertension, diabetes, all these kind of, soft tissue disorders and, things like that. So it's going to be a lot more continuity there. And you can have, now there's this newer discipline called a hospitalist, which means you're really only taking care of people in the hospital. So you don't have much continuity there. A lot of internal medicine people will have a blend of both, an inpatient service and then an outpatient service. But you can, if you don't like the continuity, you can be internal medicine, but just be a inpatient hospital type thing where people just come in, you take care of them, and then you get them back to see their primary care doctor. Hopefully that answers your question a little bit.
Yeah, definitely. And just one more to add on to that, kind of tagging along with the same idea, but more to your own personal journey. Once you did realize that, surgery was for you, you wanted to go down the general surgery route, how did you come across the idea of subspecializing, going further past that, and also specifically subspecializing in colorectal surgery instead of, for example, something like neurosurgery or something like that?
Yeah. So your med school is typically 4 years. There's a couple medical schools now that are doing a 3-year track for like primary care, but for the most part, it's 4 years. And the first 2 years are a lot of just learning science, a little clinical exposure, not a ton. In that third year, you get more involved. And so I didn't really rotate on surgery until about halfway through my third year, and never even considered surgery at all. I was family medicine all the way. But then when I did surgery, I realized the hand-eye coordination was something I felt like I could handle. The stamina wise I could handle. I understood the disease as well, like all these bowel obstruction things I was just talking to you about. Like, to me, that mentally, it's not hard for me to wrap my mind around. Fluid flows through a pipe. There's a twist in the pipe. The fluid can't flow through. So it's like you just go in there and you untwist the pipe. That to me, that isn't a hard stretch for me to understand. So I felt like that I could do well at that. Then I needed to talk to my wife and say, hey, what do you think about doing, 5 years of surgery training, which is quite rigorous. So we were on board, prayed about it, felt like that was where God was leading, went to general surgery, thinking I was going to do general surgery. But then about halfway through that, I was thinking, okay, trauma, that's what I'm going to do. I'm going to do trauma critical care and just take care of gunshot wounds and stab wounds and car wrecks and all that sort of stuff. But that kind of got tiring to me. I didn't really like that too much for various reasons. And then I started doing more rotations in colorectal and really realized that I like doing the cancer work. I like the fact that colorectal, those patients typically do well. When you treat people with chemotherapy for colorectal cancer, they have pretty good outcomes. Whereas like gastric cancer, pancreatic cancer, liver cancer, those people don't do that well. And I didn't like that. I like that you can do colonoscopies on people, which is a really great screening test for cancer, and it works. Whereas there's a lot of other cancers, you can't screen people. So I like being able to say, listen, if we do this test, you probably will never get colon cancer. And we can, do the American economy a great service because we're not, giving people $100,000 treatments. We're just, scoping them. And then all the general surgery training that I did, all that rigorous stuff that I was doing in the middle of the night, reading about and all that, I still use a lot of that, even though I've specialized in colorectal. So if you go do like plastic surgery, for instance, you go through 5 years of training, learning how to take out people's colons and cut people's legs off and take out thyroids and do heart bypasses. But then if you decide to do plastic surgery, you're hardly ever going to get below anybody's skin level. You're just doing a lot of like cosmetic stuff, some rotational things. And so a lot of that hard stuff that you spent all that time memorizing and learning, you just kind of get rid of it. And I didn't want to do that. I wanted to continue to use the stuff that I had worked so hard to learn. And colorectal is a great venue for that. So I hope that makes sense.
Definitely.
I would say regarding that, the things sometimes that lead you to a specialty a lot of times are very different than what you would think would lead you to a specialty. Like for instance, I just assumed that people that decide to do gynecology like loved babies. There's a lot of gynecologists that really don't like babies at all. Like they like taking care of mama and they like to make sure that she's good, and they like taking care of young, healthy people that otherwise are quite compliant. You know, they're going to come to their appointments because they're concerned about their baby. And then the doctor delivers their baby. As soon as like the kid pops out, they're like, here, pediatrician, take the baby because I really don't like it. How's mom doing? You know, so then they're like taking care of mom, make sure she's good, and then they send her on their way. So it was funny to me. I just assumed that because gynecologists love babies, they love babies. But a lot of times they don't, you know. For a lot of different surgeons, they like very, very meticulous, fine stuff like vascular surgery. There's a lot of very fine, surgery there. And sometimes that's what draws them, not because they love blood cells, you know, or they love arteries and veins, but because they like the meticulous nature of some of those types of surgery. So it's just funny. And that's what a lot of med school is. It's like this self-realization of what you like, what you don't like, and then what each specialty is composed of, and then trying to align those different parameters, I should say.
Maybe I can throw out another question if
Sure.
you have time. So for the a little aside from the whole clinical side of things, for your pursuit in terms of finances with making a course, how did that idea come up? How did the initiative come up out of that, and how has the success been with it?
Okay.
Would you recommend it to people here being pre-meds in terms of finances later on?
Yeah. So whenever you go through college, in my experience, about 80% of medical students never have any class ever of any type in finance. I mean, like economics, personal finance, you know, whatever, zero. So they go to med school and they get nothing there. 4 years of medical school, you never get a class on how to bill for the services you provide, how insurance works, what does the American healthcare system work like, how do taxes affect that, how to be efficient, you know, with our billing and coding and the administration of healthcare. You don't ever get any of that stuff. So then you go to residency and it's more of the same. You're learning how to be that particular type of doctor, no finance education. So after 4 years of med school, or 4 years of college, 4 years of med school, 5 years of surgery, 1 year of colorectal, I went to my first job and had no idea how to handle my finances. And I thought to myself, I want to make sure that all the people that I interact with as a trainee at a hospital or as a trainer at a hospital never are as deficient as the way I am right now. And that was in 2010. So I just developed this course to help teach doctors about how to manage their money and also how to deal with the business side of medicine. So I didn't really realize it at the time, but it was the only course like it in the United States. And so the course now is about 20 hours of content that we give to our fourth year medical students every spring. And you know, as you read in the intro, there's this guy called the White Coat Investor who's a blogger. He doesn't, at the time when I started my course, he didn't have a course. He's kind of come up with some things now, but it's a little different than what I do. But he gives out a award once a year. He's done it twice now, or 3 times, to the Financial Educator of the Year. You know, so I won that award because of all that I've been doing as far as teaching, you know, our students about how to manage their money. And so what we're seeing is that when you create a budget and you really ratchet down your spending, you can graduate medical school with less debt. And so to your question about does it really matter for you in college, I think absolutely. I think you need to try to minimize how much debt you incur in college as much as you can, because for the most part, whenever you go to medical school, all that college debt you incur is just going to keep compounding. Like you're not going to be able to pay it because people don't have jobs in medical school. You can barely keep your head above water. And then in residency, you're making 50, 60,000 a year, which is great, but you have now like expenses. You know, people think when you have MD behind your name, you immediately start making doctor salary. You don't. You make about the salary of a teacher. while you're in training. So 50, 60,000 for 3 years, 4 years, 5 years, depending on how long your training is. Then you finally make the doctor money. But when you make the doctor money, you've now got, 8 years plus of accumulated loans and interest and debt that you now have. The average medical student graduates with about 207,000 of med school debt. And so you're that plus college. I mean, there are some people that go into family medicine that actually, if you just extrapolate it out, will never actually make enough money to pay off their student loans. Like their income, because we get hit so hard with taxes, you never actually make enough to ever totally get out of debt. And that's terrible. So you can begin to fix that problem now by minimizing how much you're taking out, working on getting scholarships, doing, jobs there at college if you can, working in chemistry labs, as a teaching aide or whatever. But just do as much as you can to try to minimize that debt and not just forgetting about it. And that's what a lot of us do, is we just say, oh, one day I'm going to make tons of money and I'll be able to wipe my head with $100 bills. I'll be so filthy rich. Well, it's not really true, because doctors don't make quite as much as they used to. So you've got to be smart starting at your level. Okay, yeah. So question about your role as special advisor for physician education at Aptus. So there is a group here in town called Aptus Financial. It's 3 people that are certified financial planners. Same kind of concept a little bit as like an Edward Jones or a Morgan Stanley, like they're advisors. But if you think about financial advisors, there's 2 big categories. One is they will invest your money for you and take a fee. Another group is only offering you advice. They don't actually take your money and invest it for you. They just say, hey, you're a smart person. I would recommend you doing this, this, and this, and go take care of yourself. The only fee we're going to charge is the last, 3 hours we've been talking to you, and that's it. Whereas this group over here that I first mentioned, when they take your money, they invest it for you, but they constantly charge a fee every month, and that's the way they get paid. So this group, Aptus Financial, is this group over here. They only charge for advice. And I love that model. I think that is absolutely the best model, because they are not incentivized to sell you anything, to try to get you to buy a product of some sort. And so for doctors, we spend a ton of time learning about medicine and science. We don't know finance. So we can walk into somebody's office and they can give us a good argument for why we should give them our money. And we're like, well, money, I know science. Here, take my money and do smart things with it. Well, for this model over here that I mentioned first, they can charge really high fees to manage your money, but Aptus doesn't. And so my role is to kind of help be a link between this company that I think has a great model that allows doctors to use their smart brains to manage their own money, and me to kind of be a liaison to them to say, look, this is what doctors are struggling with right now. This is where you guys can help. These are problems when I go talk all over the US about finances that I'm seeing about student loans. And now that we've got, new legislation from the Biden administration, what does that mean? How can you then go out whenever you are an advisor and tell them accurate stuff and help ease the doctor's fears and show them what can be done to help be more appropriate, with their money. So I don't make anything from it unless I charge, by the hour whenever I give advice. But that one thing you have to watch for when you're employed by a hospital like I am, you have to be very careful not to have conflicts. So I do Aptus stuff, not very commonly, but I help them some, but it's never on my hospital time, because then I'll be getting like double salary. So if I do anything with Aptus, I've got to take vacation time, or make sure it's like on the weekend or something like that when I'm not working, because you can get in big trouble if you have conflicting interests there. So it's just something you have to be aware of when you're a hospital employee, particularly for a state hospital. You don't have as many freedoms as you would if you're like you're self-employed, because then you are your own boss at that point. What other questions you guys have? Yeah, you're welcome. If you want, we can talk just a minute about, I looked through a few of your guests previously that you had and tried to kind of get an idea of who you brought on, but I can talk a little bit if you want, just about academic medicine versus like private practice. Okay. So when I was in medical school, I had no idea that I even wanted to be a surgeon, and for sure, I did not know long term what I wanted to do. So whenever I was in medical school, you go through this process called the match, and then you decide where you're going to do your training. So I matched at LSU in Shreveport to do general surgery. So during that time, I really thought I was going to go back to the home small town that I was born in, which is kind of this rural Louisiana town, and just set up practice there. But the further along I went in my training, the more I realized I liked teaching and I liked some research. I did zero research in college, did zero teaching. I was never like a lab assistant or any of that sort of stuff. I was real involved in our Baptist collegiate ministry and did a lot of stuff with them and did some different things. So I didn't have time for like extra jobs. So I didn't make any extra money, and didn't really know that I liked, like lab teaching, or like I said, sure didn't do research. So whenever I was in my training, I was like, I kind of like teaching. Like when I would have medical students rotating with me when I was a surgery resident, they would come along and I would be like, all right, hey, let's go learn how to suture. I just go take them over and we'd find some stuff and I'd teach them how to sew. Or I found that I would give lectures and things like that. And I really found that I enjoyed that. And also really enjoyed my family. You might hear my barking dog and my kids stomping through the house here every now and then. But I like hanging out with them and academics, because I am a salaried employee of an academic hospital. Some of my job involves teaching medical students and also teaching residents in training. And that can be done kind of at random times. So like all day Monday, I do colonoscopies. Well, on Tuesday, that's my teaching day. So I set up lectures. I meet, this past Tuesday, I met with some of my residents and we talked about some different things. We learned about EKGs and we did all that stuff. Wednesday, today is my clinic day. I saw patients all day in my clinic. Tomorrow is a holiday, but typically it's my operative day. So I operate all day on Thursday. And then Friday is I work on my business course and I get new speakers and I do research and I publish papers. I do all that stuff. And so each day kind of has its own little like flair, its own little thing that I do. And that is common in academic medicine. But I've got some really good friends who are colorectal surgeons, just like right down the road, who are employed by the St. Vincent Hospital that have no academic involvement at all. They are just private practice doctors who are employed by the hospital, and they either do surgery or clinic all day, every day. They never teach. They don't have to prepare lectures. They would never do anything like this. They don't do research. They don't publish papers. They don't care about any of that stuff. And that's fine. I'm not saying that one way is right or wrong, but that's just another aspect that you have to figure out what is right for you. And that information to help you make that decision just comes through the years. Like it's not something that at one point you're like, oh, it just hit me. It's a like a evolution in things as you get into medicine. But whenever I was at your level, I didn't even think I was going to go to med school until I was halfway through my third year of college. I just took the MCAT to see how I would do, and I thought if I got in, I'd go to med school. And if I did bad, I was going to go to seminary and be a preacher. So when I decided I was going to go to med school, like I said, I thought I was going to do family medicine, which would definitely not really have an academic type position. So there was a lot of stuff that I just didn't even know existed. There was worlds out there that were just foreign to me. And so as I got into it, I was like, oh, look at this. Now I'm faced with an issue, do I do this or this? And so then I would learn more about each one and just kind of like put myself in my mindset of, okay, I'm a private practice person. Same thing pretty much all day, every day. Do I like this? Or let me think about academics. Do I like teaching? Do I like having, a little bit more flexible schedule? Do I still want to be involved clinically, but maybe not all day, every day, typically academic work makes a little less salary, but for me, I'm okay with that because I have more flexibility and I do more of what I want. I could make probably 50% more than I do right now if I went to a private practice job, but I would rather have more of a quality of life than just kind of be busting it all the time, if that makes sense.
Maybe I could throw out a question out there, kind of going along with your point regarding academia versus private practice. Before you had jumped into, the years of being in attending like you are now, what was it like, for example, in medical school? what were your possible, maybe, being pre-medical students, we don't always have that experience ahead of time to rely on. So it comes with the years, but are there any misconceptions that you think are kind of circulating around regarding life in academia versus private practice, or anything you'd like to add on to your discussion from there?
Yeah, so I think that's a really good point. And I would say to that, there's a lot of discussions about quality of life and can you be a family person with this profession versus this profession versus this profession? Like, what if I have outside interests? I want to, every year go hike across Europe or whatever, whatever it is, which profession lends itself to the lifestyle that I want? And I would say to that, there are definitely some that are more rigorous than others, no question. And there are some that are have different constraints as far as how much you're in the hospital versus the clinic, and that kind of thing. But I generally think quality of life and flexibility are more related to your own personality and your own drive than they are the discipline. So what I mean by that is I would say I could have done family medicine, but my first 5 years out after I finished my fellowship, I didn't do a good job of spending time with my family. I still was just kind of in this like workaholic mentality, and I wanted to be really great, and I wanted to publish a lot of papers, and I wanted to be well known, and I wanted to be well liked, and I wanted to be the guy that people could count on. And so I spent a lot of time at the hospital. And I think I would have done that same thing if I was a surgeon, or if I was a internal medicine doctor, or a pathologist, or a family practitioner, because it was more of like my internal drive to try to be the best, And so I think that is common in a lot of pre-med and medical students, because you wouldn't be where you are if you didn't have like this internal drive to try to be amazing, right? But at some point you've got to figure out, okay, what are my main priorities? For me, my priority is my faith, my family, and then my job. And so for me, my first few years, they weren't in that order. I would say that they were, but there were times when I put them out of order. But so because my job is number three, what that means for me is more than likely I will never be the president of any major society. I'm not going to win any unbelievable like awards, Nobel Peace Prizes or anything like, from a society. I probably won't ever be like a department chair, because to do those things, you have to neglect something else. And that is a compromise that at this point in my life, I don't want to do. So I think definitely there are intrinsic demands of different specialties that you have to just be aware of. But at the same time, you also have to be aware of your own personality and your own drivers and your own things that could get you in trouble, regardless of how easy, your specialty is. If you stay up there all the time, whether as a medical student or as a resident or as an attending, you'll be great, you'll be loved, and you'll probably have a lot of opportunities to stand on a podium, but other things just won't be around. You just can't do it all. We've only got so much bandwidth. Did that answer your question, Michael?
Yeah, definitely did. In terms of being pre-medical students, being, with those listeners out here, mostly being a pre-medical base. So, we have medical school to look forward to, the admissions there. But in terms of residency too, how do the aspects of, for example, extracurriculars, possibly GPA, what type of major you had, how do those carry on to residency? How do program directors look at that? I know that it's years ahead, but I'm interested in hearing about, does it really make a difference about, the extracurriculars you were doing back in pre-med years, the GPA you had, things like that?
Yeah, we generally say that whatever you're applying for, you go about 2 steps back. So whenever you are applying for residency, they will look at what you did in medical school, and they'll look at what you did in college. Whenever you're going for fellowship, they'll look at residency and medical school. First job is usually like fellowship and residency. So that's not a rule that I've ever seen like written out, but I've just noted, because I did admissions I still do admissions all the time. So that's about sort of the cutoff. So right now, getting to medical school, definitely college is huge, but that will only carry you so far. You've got to kind of continue to show excellence as you go to the next level. But things that I think look good from a medical school admissions standpoint, some people would say, oh, it looks great on your application if you're applying for medical school, if you were actually an English major or whatever. We probably have maybe 5% of our students that are non-traditional, that were pharmacists or lawyers or English majors or whatever, other careers. But most people are a science affiliated, whether it's chemistry or zoology or animal biology or something. So most people do science. But a lot of the interview process is showing that you're not a flight risk to start medical school and say, well, it's not for me. So shadowing and stuff that you do in college is helpful, just to say, I've been there, I've been in the clinic, I did X number of hours, and I know this is really what I want to do. Because if you bail out of medical school after the first year, well, that's a vacancy for the next 3 years, and that medical school is losing money, because they could have gotten a student in there that's going to pay for all 4 years, so they don't want that. So showing that you've kind of been around and you know what you're getting into, that you're well rounded, extracurriculars, whether it's sports, intramurals, campus organizations, whether it be faith-based or sororities or whatever, just showing that you're not like this, one faceted sort of individual. You've got kind of different things, because when you go for an interview, you want to be able to just talk about lots of stuff. Doing things like this is really great because this is just not common, so this will spark some really interesting chatter at an interview, and this would help you stand out apart from the next candidate who walks in the door right after you. To say that you guys kind of started something like this would be really great, or participated in something like this, or started something like this at your own school or whatever. It just shows initiative. It shows follow through. It shows that you're more than just an idea, that you actually can put, pen to paper and make something happen. So those are things that typically look good in an interview. And then just personality, flexibility, just being able to loosen up, stay formal, but be able to just talk with people, and just show that ultimately, whenever you have a clinic, you're not going to be some unusual individual who can't keep a patient in their clinic because they can't have social skills. Like you've got to be able to show that you're friendly and you'll be able to get along with your peers and be a good team player when it comes to medical school.
Definitely. Thank you for that insight. And a little kind of similar to that, a little parallel to that earlier question, in terms of how medical schools and residencies are categorized, what kind of applicants they look for. Like, for example, with medical schools, they have a ranking, I think on US News and World Report, between medical schools of research orientation versus kind of community service, volunteer service. In the same sense, do residencies, you think, have that kind of same structure where certain residencies look or seek out for research heavy applicants and others seek out for service heavy applicants?
Yeah, there is a difference there. And that again is just something that you would kind of want to figure out. But I mean, a lot of the names that you would recognize that have TV commercials or list standards of care and different things, Ohio State, Mayo, Hopkins, Cleveland Clinic, those kind of things. Those are going to be the ones that are going to be your academic-y, researchy sort of ones. Hospitals that you probably have never heard of, or maybe like satellite campuses from some of those big ones. So for instance, UAMS is in Little Rock. We also have our Northwest campus, which is actually in Fayetteville, which is where the University of Arkansas College is. But we have medical students that are there, and we have residency programs that are there, but they care very little about research. They really want to train those people and then to release them right into the community, right back into, kind of the Northwest area. Whereas in Little Rock, we're still trying, to get people to come here that are like wanting to crank out papers or want to get NIH grants, and do all these things to bring in money to the institution. So it may be that the institution actually has both. But yeah, there are ones, and if you really know that you just want to go back and be a community doc in whatever state, then those community type programs are absolutely fine. Some of them, as I mentioned earlier, actually have 3-year medical schools instead of 4. So then that's great. A lot of them have scholarships that if you want to go back and do community underserved areas, oh man, they'll pay for your med school for you. So go to those type places, because that matters. Carrying that debt out can be huge. And one thing that whenever you were asking me the question, I thought about was, a lot of people would think, okay, do my career goals require me to go to big name, maybe like private medical schools that are going to be a ton of money versus like state schools. And really, there's not a lot of great data to say that by going to the much more expensive medical school, it's going to propel you that much further in your career. Same thing applies with undergraduate college. There may be the occasional time that if you went to Harvard, which is like MGH or something like that, that you might get some position because you've got some of those names associated with your resume that others wouldn't. But generally, it's more about how you're performing academically, how you carry yourself, your initiative, what you're able to do, rather than you actually having a name. Because if you're a deadbeat, doesn't matter what name you have on there, they're not gonna want you. So it's much more about your initiative and your own drive than anything.
Yeah, and that's the great thing about the process. Doesn't necessarily rely on where you came from, more so, your own personal experience ahead of time. So I think that really wraps up our session today. Thank you so much, Dr. Mizel, for coming on. We really appreciate it. It's a great session, a lot of insight, both in your own practice within medicine and also a little outside in terms of, like we discussed, admissions, finances. It's a great session today. So thank you so much for taking some time to join us. But for our audience, to receive a certificate for this session, you must pass the quiz on our website, and that is now uploaded. Be sure to join us for our next virtual shouting session with Dr. Allen on November 17th at 7 p.m. Central. Once again, thank you, Dr. Mizel, for joining us. We really appreciate it.
You're welcome. If you guys have any questions, feel free to shoot me an email. I'll be happy to help any way I can.